Now to the discipline of drug utilization, and for this particular presentation I need to give credit to Lotte Rasmussen, a colleague of mine who helped me divide the slides. As I said in the introductory presentation, pharmacoepidemiology is the study of the use and effects of medications. Sometimes the use part is forgotten, and we only talk about pharmacoepidemiology as the study of outcomes and effects of drug use. But the use patterns, the drug utilization part, is certainly also a part of pharmacoepidemiology. One clever way of describing this is by Elsie et al., who described pharmacoepi and drug utilization research as one overlapping with the typical sort of drug utilization health service research metric or types of studies. Another wonderful way of describing this is the two elements I described of pharmacoepidemiology: the outcomes of drug therapy and the prescribing, dispensing, and consumption of drugs, the use pattern, and this is what I denoted as pharmacoepidemiology, but also the underlying factors influencing drug utilization, which is sort of part of the drug utilization research as well. So this is I think, clever way of describing what is drug utilization, how does it overlap with pharmacoepidemiology. Overall, the use of drug utilization methods and describing drug use generally aims at facilitating the rational use of drugs. What is rational use of drugs? This is the WHO definitions, making sure that patients receive medications appropriate to clinical needs in doses meeting their individual requirements, etc., etc. And while this sounds simple, we need to measure this to make sure this is actually met in the real-world setting. A starting point for much drug utilization research is the WHO Collaborative Center for Drug Statistics Methodology. They are, among other things, maintaining the ATC and DDD index. The ATC is a drug structure so that we can divide all drugs into this hierarchical system and identify single drugs and drug classes. And the DDD index is a measure of the expected average amount for an adult user of a drug using this drug for 1 day. This is not particularly clinically anchored in most cases, at least it isn't, but this allows not only for this hierarchical structured way of assessing drugs and drug classes, but also to compare drug use across individual drugs using these DDD measures as a proxy for their individual potency. Some of the core questions we address with drug utilization research is questions like: why is the medication prescribed? Who prescribes the medication? Who is the medication prescribed to? Are they taking the medication correctly? Is it used according with guidelines? Does the consumption of medication vary across characteristics such as region of residency or age or sex? And what is the effect of regulatory initiatives on the use of this medication? We can use very many different techniques and very many different measures and metrics to identify or answer some of these questions. Drug utilization would typically include incidence rates, prevalence proportions, the use of single substances, the total duration of use using different methods, the co-medication among users of a given drug, but are they also using of other drugs, potentially explaining the drug use, metrics such as the estimated daily dose in addition to the duration of treatment, the prescriber profile, who is initiating this and that type of drug, differences across regions, for instance, and skewness in use. Many places, including Denmark, have publicly available aggregate drug statistics, and sometimes we see drug use studies or drug utilization studies being conducted with no access to individual level data, but simply using these sometimes publicly available aggregate drug use statistics. And as an illustration of what can be learned even from aggregate data, here is a study by some of my colleagues on the use of SSRI products among women in adolescence, or girls in adolescence, comparing the 3 countries of Denmark, Norway, and Sweden. And while this contains no individual level data, but only aggregate level data, this readily illustrates the fact that there is some change in the use patterns in around 2010 and 11, after which Denmark changed their use of these drugs to a profile more corresponding to Norway, whereas Sweden now has a very different use pattern compared to the other two countries. This is a very simple illustration, but it's just to prove my point that this does not necessarily have to be individual level data. Quite a lot can be learned from aggregate level data as well. When we have individual level data, we can perform a lot of very detailed analysis. And here is an example of the use of glucose-lowering drugs, a study we published very recently. This is a metric of rate of new users, that is incidence rate. And this illustrates that across 4 different strata of age, we saw an increase in the rate of new use of this drug class or this type of medication up until 2011, after which it declined quite a lot. And we know this correlates with inclusion of new diagnostic criteria. And these new diagnostic criteria quite obviously led to a slowing down of the accumulation of new users of glucose-lowering drugs. We also saw a rate of new users that increased in the very late study period. And here we subdivided this into whether this is new users initiated by general practitioners or hospital physicians. It's not used as much as I think it should be, but the idea of looking into what sector is driving changes in drug use patterns is illustrated by this. And when we look at the type of drugs used among new users, here specifically among general practitioners, we see that in sort of 2005, most initiated metformin, but a substantial proportion also initiated SU therapy. And this has completely disappeared over the study period, and with metformin being the dominant first-line treatment. But in 2021, we saw a sizable proportion of individuals initiating first-ever treatment with GLP-1 receptor analogs. So a change in the use patterns corresponding or correlating with this increase in incidence. Whereas for the hospital physicians, there is a slightly different structure to these first-line treatments, with metformin being less dominant, but also in more recent years, a sizable proportion not necessarily initiating GLP-1 receptor analog, but initiating SGLT2 inhibitors. Again, illustrating the differences in drug use patterns across the 2 different sectors, but also how one way of investigating what is first-line treatment and how is this different over time. Another illustration of this is the complexity of treatment. Here is a histogram of the most common individual combination treatments. And for instance, you can see that metformin was used by, single use of metformin was used by 28% of the population. And then updating over time how very many different drugs entered the treatment of this disease, and that now the drug use pattern is much more complex compared to the initial situation in which we had 6 different types of treatment being dominant. We now see 15 or 17 different types of combination treatments in the population, denoting a markedly increasing complexity of treatment of this disease. So what? This is just a few examples of how drug utilization can answer very specific questions. And this is actually typically the case, that drug utilization requires more tailored analysis, more sort of handheld and detailed, instead of sort of more boilerplate type analysis in outcome studies, which I think is one of the very many reasons why this type of research should not be underestimated. But there is a few things to remember when doing this. It is quite important to focus specifically on bridging the gap between the drug utilization study and the clinical reality. This might, in many cases, be a reason for why you should include a clinician, and in particular a currently active clinician, to sort of help you tailor your drug utilization studies. Because we might end up from the ivory tower of the registry-based research lumping drugs together that in clinical reality should not be grouped together, or having metrics of use where we combine two different populations that are in clinical reality intended to use these drugs very differently, etc. So to make your drug utilization study as relevant as possible, please consider including a clinician. And of course, also in your study, address how will this research question, how will this analysis inform the rational use of medicines. If you would like to see more examples of or more input to how to design your drug utilization study and what type of questions can be answered, and an overview of different methods that can be used to address these types of questions, there is this core concepts paper written by Lotte Rasmussen in Pharmacoepidemiology and Drug Safety. There's also this wonderful methods book by Elsevier et al. On drug utilization research methods and application, with quite a lot of the drug utilization experts from within our field having contributed to the very many interesting chapters in this book.